most people, your SPs, when you said we'll bring you in, they probably said, I'm here for fun. From, taking this medicine and you got us synthetic. And you said, okay, so how's everything going? How are you feeling? And you probably said, better. And then what do you ask? Like, what is your job at that point? Is that like your HPI? Or what do you still need to do in HPI? What do you think? Right. I think so. So that note that you had from the previous visit, if you use that in this visit, that was pretty smart. Because it's kind of like a guide. So I think some of you did and some of you maybe didn't. Maybe you thought you couldn't, but you could because you took it in there with you. So, right, some people struggle, I think, in the very beginning. I think you all came to, in the end, figure out what's going on and what you wanted to do. But I think some people struggled in the beginning, like, what do I ask? I asked these things the first time I saw this person, just to do it better, like, how much do I go into the HPI and how do you, can you necessarily ask all parts? So, not some, but your job is to make sure that you agree with that prior diagnosis, right? And to get an interval history. So what's happened since we last saw you, since you've been on this medicine? Things are getting better. Your next question is, how so? In what way? What's better? Is it that you're having panic attacks anymore? Is it that you're having them less? Is it that you're still having them the same, but they don't feel as intense? What exactly is better? And how have these episodes changed? Because maybe they aren't the same as they were 6 weeks ago because they're partially treated. So breaking that up and kind of getting into that kind of detail, that's what I was looking for in your HPI. And, again, clarifying what are the symptoms of your panic attacks now? So when you were here 6 weeks ago, you were having palpitations, you were short of breath, you were sweating, you felt like you were going to die, right? So much so that you went to the ER because you thought something was really wrong with you. What's on your mind now during these attacks? How are you? Remember, there's psychic, anxiety, and somatic. What's going on in your head? What are you feeling? How is that different? So really hashing that out, really important. And, okay, so let's get started. Maybe, I'll reference it as we go, but overall, I think everyone's done a really nice job. We're still in the midst of grading like crazy. So, nobody wants to have a day and make it look like if we do well, we will figure all that out. Okay. I just want you guys to be proud that you made it through. You lived to see another day. And that was a hell of a week. I mean, that was really fun. So, congrats. All right. So, first half of this lecture is going to be on psychiatric emergencies, and then Professor Jacob is going to talk about altered mental status, which honestly can go hand in hand with psychiatric emergencies and delirium and mental status changes associated with that. Some of what we're going to talk about today is just a nice review. So I may skip over some things that I know we wanted to detail about, so that we can focus on other things. But if it's a review or repeat, we're good. We're bringing it back to the portion of memory. So here's our objectives. And we are going to start by reviewing the difference between how many classes have you learned about dementia and delirium? Many, right? Psych, clin med. So let's review. So remember the other name for what we call dementia, the DSM-5, because it's major neurocognitive disorder. And this is here's our DSM criteria. These are significant cognitive decline from a previous level of functioning in several different cognitive domains. And so you can have a decline in attention, executive functioning, like organizing, planning. You can have a decline in memory. I think that's the one everybody kind of thinks about with somebody who has dementia. Language, perceptual motor, and social cognition. So this is a gradual decline in one or more of those domains. How is the gradual part different in, if we were comparing dementia to delirium? Dementia is a gradual decline, delirium is a one. Acute change, right? Or like a waxing and waning of attention. So dementia is different than low intellectual function because it really represents a change from a previous level of function. Right? When somebody with low intellectual function has that level of function their entire life. So this is a change from a prior level of function. The cognitive deficits of dementia interfere with what? What kind of activities? Say again? What kind, memory, but what, okay, but what kind of activities? Okay, so we've got instrumental ADLs and we've got regular ADLs, right? What are our activities of daily living? Showering, toileting. What else? Brushing your teeth, brushing your hair, caring for yourself, grooming. Okay, and then what's the difference between ADLs and IADLs? What are those instrumental activities of daily living? Driving, financial, like ability to pay bills, things like that, keep up financially. Okay, good. All right, so contrasting that dementia to delirium, we said this is more of an acute change in a patient's level of consciousness and their level of awareness. But delirium is not a disease, it's a marker for some form of medical illness. So I like to compare it to a fever, right? So if Erin came in today, she has a fever, we don't know, there could be all sorts of underlying reasons why she would have a fever today. So the fever is a marker for the illness, we have to get to the bottom of the illness. Same thing with delirium. Someone has this acute change in their awareness, their consciousness. Why? In the emergency department, do you think you may see people present delirium? Especially the older population. Because remember we talked about in the geriatric section, you're more susceptible to, your brain is older, more fragile, you're more susceptible to these kind of functional and mental changes as you get older. So delirium is a very common diagnosis made in the hospital, in the emergency room. And about 10 to 40% of inpatients become delirious during admission. So if you didn't come in a delirious state, presented to the ER delirious, potentially you're admitted to the hospital, you're having a workup, you're on different medications, you have potential to develop a delirium. And bringing it back, remember we said that you can't diagnose any other mental illness in the setting of a delirium. Because delirium can mimic lots of different mental illnesses. So we have to rule out delirium before you can diagnose schizophrenia, any mood disorder, dementia. There would be some criteria that we essentially just minimum. But this is applicable to the emergency room because we're gonna talk about how would we work somebody that has this acute change in awareness or mental health. This is just a chart that you've probably seen before. Of differentiating, because this is a big deal. This, I'm sure this is gonna be one difference, differentiating someone who presents delirious versus with dementia. Can a patient who has dementia get delirious or have delirium also? Definitely, definitely. So how would you sort that out? It could be tricky. You either have a baseline level of cognitive problems, and now they're presenting, but with delirium, they're gonna present with an acute change. Something's different and it happens quickly. With a delirium, it's their consciousness is gonna kind of fluctuate, wax and wane. What test, paper and pencil test did we do to track delirium? Say it loud and proud.
Mocha.
Not mocha. Mini mental. Mocha is more for dementia. Mini mental status exam to track some, if you have a patient who's delirious, let's say they are admitted and they're delirious, they score a 10 out of 30. 2 hours later, you do another mini mental, they have a 30 out of 30. You know, that their awareness fluctuates, rapidly. Somebody with dementia, if you do a mini mental status exam, what are their numbers are going to decline over a longer period of time. Right? They're not going to come up and down, up and down. Okay, so what do we, if we're in the emergency department and we have somebody who presents a 75-year-old who does not have a history of dementia, presents, you know, brought in by family, saying they are just acting erratic, strange, don't seem to know what's going on. This is an acute change. I brought them in, you're confused. You're in the emergency department. What basic tests, things are you gonna, yes, you're gonna do a thorough H&P, but after that, what things do we wanna order to work up? Okay, so tell me why, so you see a new way.
For infections.
Definitely, good. Those are two classic definite studies that you want to get, okay? What else?
Depending on how they're presenting, consider like screening for stroke, and pulse screening maybe.
Yes, good, very good. So you're gonna do that physical exam, maybe you might find some deficits on physical exam. Maybe you need to do some sort of tag imaging. And definitely consider tox screening. So that means you have to take a good history of things that they could have been exposed to or current medications that they're on that if they take too much of, or is there levels of it? Absolutely. What else? EKG, why? Okay, good. Definitely want to do EKG. What else?
Yeah. Glucose and finger stick.
Yeah, glucose and finger stick. Why? Yeah. Did we say a CMT? We didn't say a. Definitely, right? And that's gonna be in the CMT that he's supposed, but we want to check electrolytes. Is there some sort of imbalance? What else? Alcohol, yeah. We want to get a good history about that, and you can't, I mean, depending on like a urine tox is not too much, doesn't show alcohol to get a blood alcohol level. And again, your history and physical are gonna kind of lead you to what specific things you're gonna need, but everything that you guys have mentioned is usually part of a biological protocol. Would somebody else have any? Yeah. Would you do that right off the bat? Okay. When would you do it?
I guess that would be more like the chat, right? So I guess we would probably start with that, but it's allowed.
So what would you start off with? And if that came back at normal, you might want to consider that. Yeah. Yeah. If you get a CMP and you've got a macrocytic anemia or a microcytic anemia, then you may want to, then that might lead you to, oh, so that's a macrocytic anemia, I'm gonna check. Chest X-ray, potentially, if they've got, symptoms, cold, chest pain. Good. And last question specifically about delirium. How do we manage delirium? How do we treat delirium?
Leave it under small.
Yeah, we treat the underlying cause, absolutely. So we've got to get to the bottom of what it is first. And then, yes, we're gonna treat that. You really want to optimize safety. I think I've heard a lot of detailed stories about patients that you were around that were agitated with even delirious. And you see that kind of agitation, and how do you keep them safe in a hospital setting or in the emergency department? Restraints, I mean, that's one possibility. We're gonna talk more about that today. What else? Sitter, right, a CO or a sitter. And what is a sitter? A staff member or somebody sitting with them, watching them, making sure that they're safe, maybe helping them or reminding them that they are, giving them orientation to where they are and that they're okay and that they're safe. Do we want to strap restraints on everybody who's delirious? No. Why? I mean, it's easier, right? Nick gets out of hand, that's what it is. Why is that not smart? Yeah, you can make it worse. You can make it worse. I mean, if you're really confused, you don't know what's going on, and now all of a sudden you're held down, you're in restraint, that's even more scary. I'm not saying that sometimes it isn't necessary, right? Sometimes it is necessary. But it's definitely not your first thing you go to. So let's kind of talk about the steps that we take and how we consider somebody that presents to the emergency department who has a behavioral disturbance. So you should know, I mean, a lot of you are probably gonna end up loving ER because lots of students do. It's a fun, exciting place. But you should have some sort of background in understanding that a lot of your patients, if they don't present with some sort of behavioral health complaint, if that's not their reason for visit, often about a third of them in some fashion have some sort of underlying mental health issue. So important for you to know if you're going to be into dark clinician. We've kind of talked about how the ER can be a confusing place and healthcare systems can overall be very difficult to navigate. If you've ever had a family member who's been hospitalized, like my mother-in-law was hospitalized recently, it was a hot mess. It was very difficult, even for somebody who knows generally how it works. So keep in mind that, the emergency room is a difficult place for all patients, but definitely patients who have some sort of psychiatric problem or some, mental status change. So for you, your job, even if they're a real pain and they're hard to handle and deal with, is to stay positive, stay non-judgmental, and try your best not to get frustrated. Because that reflects onto the patient. How do they feel that? So emergency psychiatric assessment steps in the ER. These are important. First thing we want to do is make sure that we are addressing safety and stabilization. So the patient comes in and they're not stabilized medically, that's number one. We need to make sure we attend to their airway, their breathing, their circulation. Safety, if they're violent, we need to address that first and foremost. We'll talk a little bit more about that. Step two, identify any suicidal or homicidal ideations or other dangerous behaviors. Again, because we need to keep everybody safe. We need to keep them safe and themselves, and we need to keep them safe, ourselves safe sometimes from a violent or dangerous situation. And, you know, the patient presents with like agitated or violent, it doesn't mean that there's a nasty person, obviously. Maybe they are, but maybe they've got something going on that it's hard for them to control. Step three, always medically evaluate your patient next. If you didn't medically evaluate them before you evaluate them, so yeah, why?
Could be the cause of the something. Because the medical issue could be causing the sickness.
Exactly. You know, you've been taught very well that you have to rule out any medical cause of these abnormal behaviors, conditions, before you can say, oh, they must have schizophrenia. So definitely a medical evaluation. You need to determine whether there's something organic going on that's causing this problem. And then that's the patient can treat that. Okay, then we get to if they're medically cleared and evaluated. So our patient, our panic disorder patient, she went to the emergency department, feeling like she was gonna die. She couldn't breathe. She was having palpitations. She thought maybe she was having a heart attack. The medical team evaluated her and did EKG, did blood work, did an X-ray. Everything, their workup was normal. They weren't concerned that she was having a heart attack, having a stroke, having some sort of underlying medical condition. And so then we get to, okay, well then, if we've exhausted the medical workup, let's talk about the psychiatric workup. And what would we include in a psychiatric evaluation? What does that mean when I say psychiatric evaluation? Yeah, for sure, mental status exam, but maybe even a history focused more on, you know, what's going on mentally. And what are the components of a mental status exam?
I don't know.
That's a good question.
Great question.
I realized that I had the answers on that paper.
I didn't work with these smarter, not harder.
I'm sure this is good. I think some of you did, fine. I mean, I can't blame you. I didn't, you know, I give it to you. Some of you just didn't. Like, oh my God, you did. But apparently I listed more than 8 or 12. So you had to figure out what would be 8.
I just put them all.
Also, my
Like
goal
one
is-
slash. Yeah, no, that's smart.
It's like thought content
All right.
I made it in the
process or whatever.
Yeah.
So, right, so our,
That goes in-
our panic patient is in
Uh.
the emergency room, now she's-
Well, I put nothing.
I mean, and some ER have a actual psychiatric ER, some don't. You know, a Hopkins thing has a separate name, it's like ER. We were medically cleared and they thought you needed to go see the psychiatrist, we went over into that. And that was site specific, but in a general hospital, you're not always gonna have that. Sometimes they'll consult the social work team to come see the patient and use that. Essentially decide, does this person need to stay here for some psychiatric reason, or, you know, can we set up a plan and discharge? So with your panic patient, there was no reason for her to be admitted. You know, she wasn't suicidal, she wasn't homicidal. But what was the follow-up that the ER gave her? Your family patient. 6 weeks ago. When she went to the ER 6 weeks ago, and they discharged her, and they said, this is what we want you to do for follow-up. You don't need to be here in the ER, we don't think there's anything medically wrong. Before that, what's the step between the ER and when she comes back to you? No. We had a telehealth visit. Right?
We blacked it out at this point.
Where's Waldo? Really?
So she went to the emergency room. She was discharged to have a telehealth visit with your primary care practice the next day. You did the telehealth visit. Then, and you put her on Lexapro. Then 6 weeks later, I would follow up way before that, but we made it 6 weeks. She came back and that was your visit last week. Now, raise your hand, and this isn't your fault. Raise your hand if you thought she went to the ER the day before. Why do you think that? I know why.
It said that?
The doorway now.
Yeah. So that was
And I
the
was like, what?
And so, but it actually was,
She was like, no.
it was actually okay
Yeah.
because.
I was like, huh? I was like,
you
wait,
know,
for real?
And some of you said, oh, so you were in the ER yesterday.
Yes, that's exactly what I said.
I guess he or she, I'm just,
She's really referencing.
said, that was 6 weeks ago. What did you do with it? How you guys just switch up your thinking? Oh, okay, I don't have this right. Tell me. No. Right?
I said, give me a roll.
You didn't have that.
I like looked at the note again. I was like, okay.
I was like, can you just give me, that's what I said to her. I was like, can you give me a second to relook at your chart? I'm confused.
And actually, I thought.
But first I went down this, yes.
Were you able just to, switch up your thinking based on what they said? However, sometimes the SP will say things like, once, like 6 months ago.
Whatever, their own drum.
All right.
I don't know that's
What do we term or what do we classify as a mental health emergency? Well, what would you think would be a mental health emergency? I mean, this lady presented to the Aero Panic Disorder, that was what else? Suicidal ideation, homicidal ideation. Violent behavior. So let's kind of break down. Yeah, so you don't want to do this.
No biceps.
Try right now.
Let's break down our previous slides of this, kind of step by step. So we're gonna talk about safety and stabilization. which is like first step. So a patient comes in, we need to make sure everything is safe and we can make sure that I'm safe. I'm not gonna focus on the medical part of it because that's what you've got elsewhere, in your entire ER. Yes, sir. We took some place part of it. So we're gonna triage them first. We're gonna weigh the level of agitation. Were they brought in by the police because they were agitated? Did they walk in off the street? They're just anxious. What is the level of agitation? What is the risk? Did they come in because they want to hurt themselves? Did they come in escorted by family because they did hurt themselves? Did they come in, a medical emergency after the self-harm? So safety, stabilized. Part of that is, if we're concerned about some of those things, we're not going to leave the patient alone. If they're suicidal and living in a room, come to hang out and get to them. Is there anything you can do when you're alone in a room to hurt yourself? Yeah, I work on some intake psychiatry. But what if they have something sharp on them? That leads me to the next point is, if you've got a patient who you're worried about this, these safety situations, you're going to check their personal things. and their clothing, you have them get in and out, right? Because you want to take away anything they could use to hurt themselves, to somebody else. Yeah.
So if someone's brought in against their will,
Yeah.
because they're suicidal, I get it. But what if someone brings them something and they say they're suicidal,
Yeah.
but they still never leave it by themselves?
Definitely. You don't want to leave them by themselves. They're
I just-
telling you, gosh, I'm having thoughts of hurt myself. And what if you leave them by themselves and they start thinking, why did I come here? This was a mistake. Nobody's paying attention to me. I thought I was gonna get help. I'm sitting here alone. Forget it. You know, and you don't need to be rude about it. Like, you need to strip down and eat all of your things so you don't hurt you, but it's just a general process of, okay, you know, in the ER, this is what we do. We're gonna give you this gown. And we're gonna have you take your clothes off, get in the gown. You know, you can do it in a way where you're explaining to them and it's not like, I think you're gonna, you know, coming at them. I mean, that person is really, really at risk because they're telling you, I've had these thoughts and they're here, but who knows? You know, when you get to the ER, it's a scary place. So your job as a clinician is to be calm, to try your best to explain what's going on, to make, okay, you know, we have a lot of patients in the ER. We definitely want to help you figure out what's going on. For now, you know, I would love it if you could, we're gonna give you this room. I'm gonna have you change into this gown. I'll take your items and I'll lock them up for safety. You know, can I get you something to eat? Can I get you something to drink? What can I do for you? Anything you can do to help them feel comfortable. And tell them what's going on. You know, but you also cannot let them walk all over you. You have to set some boundaries. Like this is how we do things. You know, this is the process in which we do. You know, some patients who aren't necessarily, like, I'm gonna show you a video, my favorite video. Nick's gonna love it. Who aren't necessarily, you know, coming in agitated or violent, but they could work themselves up into it, right? And so you don't need to put them in restraints or give them IM medicines right now. How do you try to keep them calm or de-escalate them in a verbal way without hands-on? Always speak to them calm. Sit down with them maybe eye to eye. You know, it doesn't feel so good when someone's talking over you like this. Of course, you want to make sure you're safe. So you're gonna maintain an appropriate distance from them so that if this person were to like abruptly get out and lunge at you, you can go, you know, you've got space between the two of you. And you don't put this patient in between you and the door, right? You remember the story of my supervising doctor who got beat up basically because the patient was sitting right at the door. Because she couldn't get out when he got agitated. You can't help someone if you don't feel safe. You've got to make sure you've got some distance, right? You want to help them, but your safety is supposed to be. And you're always trying to establish a rapport and let them know that you're listening to them. You know, like, this is a famous video that, you'll remember in your second year because it's like years. And you have people who cannot be controlled in that way. Up to 50% of healthcare providers are victims of violence sometime during their career. I told you about my supervisor doctor. She handled it like a champ, you know, so well. And it's unfortunate because clinicians are often unprotected and unprepared. So you have to make sure that you feel safe and comfortable. So your gut's telling you you're not safe and something is wrong and you need to make an adjustment. I think I shared with you a couple of times in my career where I felt real uneasy and I probably would have done things a little bit differently. I think a patient was trying to intimidate me once and came in a long, like, black trench coat in the middle of July. And he was only there because his mother was making him come to get a shot because he had really bad bipolar disorder and he got managed with psychotic. So his mother knew that he was kept well when he would get shot. But he didn't come, he didn't think he needed it, he had no insight, that's another thing in the panic case. You know, you would necessarily ask your patient, how's your insight? No, not really, that's the judgment call that you're gonna make. But he wasn't very insightful that he had an illness and needed the medicine, but he came because his mother basically made him. But, you know, it was just me, I was the only clinician, it was me and the front staff person. Called back to me and said he's sitting, he was kind of creepy. He's sitting in this long black trench coat and what do you want to do? And I went out there and I brought him back to my office and I talked with him. I didn't keep him in there too long. He got his injection. But the entire thing made me feel extremely uncomfortable because he walked back to my office with his hands in his pockets. So I didn't know like what was in there. And so, you know, probably should have done something different. But anyways, you need to make sure that you feel safe. And if you don't, then that's a problem. And you don't have to come in front of this person. Or you come in front of this person with backups or security, that kind of thing. Here's some of the other ways, kind of protective or prevention measures when we're talking about violence. So making sure that, you have security personnel, certainly in the emergency room or in the hospital, that is a key part of, you know, keeping people safe. Security that's well trained, that they can help when something goes wrong. Alarm systems in the emergency department and also on units and psychiatric floors. We had, we call it the blue bell, like a blue button that you push to various places on the unit. If you were with a patient, they were getting agitated, and you were feeling uncomfortable, press the blue bell, and essentially the everybody that can hear the bell, which is people on many floors of the building, come as quickly as they can, and it's sort of meant to like show a force to have the patient kind of like back down rather than you versus the patient. Controlling access into the emergency department and the hospital to prevent violence. So limiting the number of entrances or controlling kind of entryways, having buzzer activated doors, monitoring who comes in, sure. Especially in the evening hours. Caretaker education, essentially having regular sessions with your clinicians, with your nurses, with your staff, to train them in how to manage agitated or violent patients, to reduce the incidence of violence. Make them feel more comfortable.
Excuse me, is code gray universal? Like is every hospital, is like that the same in every
Code
hospital?
gray.
So I'm gonna go with no. Maybe it's just the hospital.
2015. What is code gray?
That was like the overhead intercom for like an agitated patient or like that, like
No, I don't think it's-
security intervention. It's okay, so maybe it's different.
Yeah, I think probably different hospitals.
Okay. Good.
But right, knowing those codes and knowing what that means for you when you hear that is very important.
Yeah.
It's kind of like hitting the blue bell and it's. Sitting down and talking with an agitated patient. You know, you need to, agitated in the sense that they're not violent, you know, you're speaking with them. But you need to make sure that you feel safe again. And that they don't have anything on them that they can come at you with, or if you're in a room with them, there's nothing that they can grab. And that they're not between you and the door, always. You need a way out. So, you know, putting them in a gown is a non-confrontational way to search for weapons, to make sure that they don't have anything else on, right? And I should put this down on. Definitely, interviewing them, if you want it to be private, but not isolated, you never want to feel like it's just you. Sometimes people, if there's a possibility, you can use a seclusion room to interview an agitated patient. A seclusion room is just a room that really has nothing in it. Sometimes it will have like a cot or a mattress, but there's nothing in it that can be used to be dangerous. And, you know, if you were to leave out of that room, you could shut and lock the door if the person is violent. But you don't want to interview an agitated patient behind a closed door. And you always want to have some sort of mechanism for alerting others, or you want people to know where you are, what you're doing. Or when you're around agitated patients, when you're working in the ER in general, like wearing earrings, neckties, necklaces, things that somebody can grab off of you, not a great idea. And you have to be aware of any other objects in the room that they can use as weapons. Male sex, having a history of violence, drug or alcohol abuse, all of those things can be associated with violence, but ethnicity, diagnosis, age, marital status, and education are not reliable. Sources didn't say, oh, this was a violent person. But past behavior predicts future behavior. So somebody who has a history of violence is more likely to act that way again. So knowing their history, if they've been there before, you know, reviewing their chart, knowing what's happened, it's very helpful. And usually violence comes after a period of mounting tension. If you're having a difficult conversation or a tense conversation, you can feel that tension. Typically, you know, that's when the person is going to be not always. But you've got to be really observational, really astute to identify any kind of cues. Is the person, you know, what was this guy doing with his hands? Not the clinician, but the other one. What was he doing with his hands? Right? You know, he was like ringing, you know, just watching for things like that, or clenching your fists. Those kinds of things. Those might be cues that, you know, this person's getting upset and doing let me out of here. Always pay attention to your gut feeling. You don't feel right, you're not going to be able to help them. So you've got to change the situation. For an agitated or violent patient in the emergency room, certainly signs that things are about to go wrong. Behavior gets provocative, they get more angry or loud, aggressive in their speech. Like I said, they're clenching their fists. They're really tense in their posture. They're pacing. They've got that psychomotor agitation, right? The psychomotor changes as a part of CPCAPs. Aggressive behavior. Those are all not great signs. What can we do if verbal de-escalation isn't going to work? What can we do medication-wise in the emergency room or in an emergency situation? Most certainly, we can use medications like benzodiazepines. And I heard some of you mention that in your panic cases, which is fine. So lorazepam or Ativan is one of the most useful medicines in the emergency department for agitation. Is to hopefully help calm somebody down quickly. You can give this medicine to them orally, or you can give it to them in an injection. Which way is it going to work faster? Okay. You don't need to know the usual dose. That's just on here for more information. You can give Ativan IV. If you can't give a benzo, or there's a reason why you shouldn't give a benzo, you know, maybe the patient's older and they're delirious. And so what did you learn about benzos and, you know, as a patient? It could probably make things worse. You could also consider an antipsychotic, a quicker acting antipsychotic. And that's not to say that your patient's psychotic, okay? You're using this to calm them down. Not because they're necessarily hallucinating. They may be hallucinating, but you can use it doesn't mean that they're psychotic. It's just another option that can be really effective in reducing agitation. And again, oral, IM, and then there's also ODT. Remember, we learned in the PEDS case that the low rank can be ODT. A lot of antipsychotics are oral dissolving tablets as well. So, you know, if they're not gonna take, or you wanted to get in them quickly, but you don't feel that they need a needle, give them an ODT. You must have this memorized, it's going to be on your thing. This one
I really believed her. I thought she was that serious.
Like, oh.
Right.
I like for you to just, I have this on here in case you need it for a second. You know, you can refer to a lot of your PowerPoints to help you in your specific rotations. So this is just the antipsychotic drugs and, kind of their intramuscular dose, how quickly they work. And remember, with any of these medicines, though, there's always potential side effects, right? EPS, QT prolongation, those kinds of things. So they're not benign, yes.
What's the FDA warning for the Paradol?
Nobody uses droperidol anymore. I don't know what the specific warning is, but it's not. I'll just feel lost with it.
Okay.
Never seen it, never used it once in my life, but that's what it felt like. So more antipsychotics, we're still talking about, like I said, they can be given orally. There's antipsychotics that are kind of viewed as better for like acute agitation. If you ask me, I'm not gonna give somebody who's really agitated and potentially violent because of a vilify. I don't really expect you to know that though. These are three common ones that are given for agitation. So risperidone, olanzapine, and haloperidol. Which of these three medicines is a typical antipsychotic?
Haloperidol.
Okay, and what kind of antipsychotic is olanzapine?
Atypical.
Atypical. And what about risperidone? Atypical, right. Remember, these medicines come with side effects that can be real nasty. One of them is extrapyramidal symptoms. What are extrapyramidal symptoms? What is this? Right here. Muscle tightness, tongue thickness, neck tightness. Okay, what else did I teach you? EPS, extrapyramidal symptoms, side effects. Tremor? Yeah. What does it look like when someone has Parkinson's disease? They have a feel rolling tremor. What else?
Slow gait.
They have a shuffling gait. What else? Masked faces. All of those things are also extrapyramidal symptoms. Why? What happens in Parkinson's disease to cause these symptoms? What's being blocked? Dopamine is being blocked. So when you're giving an antipsychotic, it's blocking dopamine in some form. So that's why you can look like you have Parkinson's. But also remember akathisia. Anybody remember what that is?
Can't sit still.
Say it louder.
Can't sit still.
Like uncomfortable motor restlessness. But what about dystonia? What's that? A sustained muscle contraction, yeah. that's what it is. If you give a person an antipsychotic and they develop some symptoms, you know, some QPS symptoms, be ready to take care of that. They're having problems breathing, you're gonna give them oxygen or do what you need to do for their breathing. If they have this tremor, if they've got a dystonia, then remember Benadryl, benztropine are medications that help treat these side effects. Yes. So if somebody has a dystonic reaction of their eyes, it's called an ocular gyrate crisis, and it looks like their eyes are like stuck up and, deviated, looking to one side. That's an emergency. You're gonna give them an IM or an IV form of one of these medicines. Can you develop tardive dyskinesia from one dose of Haldol? Correct, you cannot. You want me to take a break, or do you want to break in between that?
Mine is much shorter than yours.
Take a break. Okay, then we can break. Then go into antipsychotics, but,
Oh, she did. You asked what I
oftentimes
just now. Oh.
they can be using Tommy. And it's called a B52. Why is it called a B52?
It's a great band.
Hey.
52 Fighter pilot.
Oh, I figured it was because it's, Yeah. Right, Benadryl B, 5 with Haldol, because that's a typical dose, 2 of that. B52.
Really difficult fighter pilot just coming down, crashing into the ground. Isn't it be the fighter pilots, the fighter jets?
So,
B-52 too?
The
They also
Benadryl,
sing Love Shack.
a lot of people,
The B-52s.
a lot of prescribers will just go ahead and if they're prescribing a typical antipsychotic like Haldol, they're more likely to have deaths, they're have to max prescribe, particularly prevention. With it, so, they're like the Benadryl, plus Benadryl can make you sleepy and help bring you down. So let's talk about seclusion and restraint. So, remember I told you how you hit the button on the blue button on the wall or some sort of, or it's a code gray. A show of force and presence of many staff sometimes is enough to kind of get someone to calm down. If they're anything up. So, aside from de-escalation, that can be helpful. But if you need to put someone in seclusion, to protect them or staff, then, oftentimes it's necessary. You can have open door seclusion or closed door seclusion. Sometimes, on my unit, if someone started in closed door seclusion, and over time, like maybe we also gave them medicine too to help them calm down, and over time, they would demonstrate if they were more calm in the room, then we would advance them to open door seclusion. And the seclusion room is designed to be safe without others that can use support themselves or other people. We, our unit, we really didn't use the seclusion room a lot. Our nurses were very good at manipulating. So sometimes we turned it into a, what do you call it? That we turned it into like a room that didn't have that negative connotation, and if maybe we're overstimulated, you were a patient, you were around another patient on the floor, got agitated, and you just got overstimulated. Okay, another place, you can look at it like that. Sometimes people will ask, can I go spend some time in the seclusion? It's because when you're putting someone in the seclusion room, you've got to, again, tell them exactly what's going on. You have to always, you tell them what you want to see. When they do this, then you will do this, and you will do this. We can show you that they're calm, you will advance them. Like I said, sometimes people will give medicines, I will say that we had to have a few times if someone was really agitated, violent on the unit, we were security had to get involved and almost like take them down because they were so violent. So nurses could give them medication and then put them in seclusion what do you have to do if you're gonna do that? I mean, what do you suggest? Wow. That cool? You said yes. No, that's not cool. You always have to monitor the seclusion room, so there needs to be some sort of nurse monitor, somebody sitting. There's, a camp for, on the floor that I was on was a camera. And so they would sit and monitor. Because, what if your patient stops breathing, or you gave them medicine, you gave them intramuscular medicine, or you gave them PO medicine, you wanna monitor when it kicks in, you wanna make sure that they're safe, medically and psychiatrically. So, there are specific order sets, there's a specific routine of monitoring, it's very important. In the off chance that that's not helpful, then, you move to physical restraints. And usually the physical limb restraints, if they need to be applied, it should be done very quickly by people who are trained to do it. And again, you're telling the patient why you're doing this and reassuring them that you're doing it for their benefit. They may not think so. It just depends. It just depends on the patient. And again, you're going to have to continuously observe anyone in restraints. Why? Yeah, they could still. Or they could have some sort of medical emergency. So next couple of slides. So I'm not gonna go into too much detail about this, because I think that you talked about it, but just overall, if we're like stepping back now, like what is our medical evaluation? Our patient comes in with a psychiatric complaint. What does that involve? We kind of talked about how we would work up somebody with delirium. But these patients have to have a thorough medical evaluation. Actually, was actually asking, well, what if it's somebody who's, has schizophrenia, and, they come to the emergency department with hallucinating again. Like, at what point can you, like, skip a medical workup and say, this is their psychiatric illness? What do you think? You can't really ever do that. Now, there's times where if somebody is presenting the same way every time, and you gathered in their history of you gathered in their history that every time they stop their antipsychotic, they have hallucinations and delusions, and here they are in the ER again, because they stopped their medicine, and they're having the typical symptoms that they always have. That leads you more to believe, I think this is an exacerbation of their psychiatric condition, but you still have to do something. You might not just go chasing down, you may not do brain imaging. This is someone who's had schizophrenia for years. Right? And they're presenting in a way that makes it, you're going to do some blood work, you're going to do a tox screen. You're going to get a UA, you're going to do typical things like that. Always. Getting their history, what are their medical comorbidities, their drug history, you're going to perform a physical exam, you're going to perform a logical exam. Anybody who presents with like a sudden major change, that's suspicious. We need to really think about our medical. If it's your patient with schizophrenia, who this is his typical when he's not compliant, okay. But if it's the same person and he's presenting now in a different way, not with his typical solutions, you need to catch that, and that may warrant a different kind of evaluation. Behavioral changes, and we talk about this, due to misusing medicines or misusing prescriptions, misusing over-the-counter drugs. It can be due to alcohol and drugs. Alcohol and drugs can produce psychosis. So you might say, oh, wow, this is new onset schizophrenia, but the person, has been using PCP. So always think about substance and getting a top screen, getting that history, looking into that. Or picture it's benzos can produce kind of a confused state of delirium. Being intoxicated or even withdrawing from, drugs or alcohol can present with all sorts of mental illnesses. So this is more about the medical side. Just, you need to do an appropriate medical evaluation. And with special attention to a good neurological exam. If someone is presenting with any of these types of things, you're worried that it's an organic cause of psychosis, meaning it's a medical cause, it's not from a mental cause. So their vital signs are out of whack, disoriented, they have memory loss. They're over 40 without a previous history of psychiatric. So some illnesses, psychiatric illnesses, typically they're going to present in young 30s. Like what? Not depression and schizophrenia, bipolar disorder. You would expect if somebody has those types of illnesses that they're not going to all of a sudden present with hallucinations at age 50. It can happen. You can't rule it out. But the typical course is you're young. If you're a guy, what age are you if you're a guy? Yeah, like late teens, early 20s. What about female? Later 20s. And then bipolar disorder, anywhere from teen to late 20s. So, if you have someone, a 50-year-old who presents with new onset hallucination and then no prior psychiatric history, that's something medical. Maybe they get something. Vocal neurological signs, that you definitely need to work on. Visual hallucinations, those aren't common if somebody has psychotic illness. So again, work up who might have visual hallucinations. Less schizophrenia.
Corsica? Wernicke's-Korsakoff?
Okay, Wernicke's-Korsakoff, good. Drugs, dementia, delirium. We already talked about these things. You should all be experts now in mental status, but doing your psychiatric evaluation in the ER would definitely, you told me this earlier, include a mental status exam. And as we know from our candidate experience, that there's certain questions that you can ask, like how's your mood today? Have you noticed any abnormal mood rings or tremors? Do you have any thoughts about hurting yourself? Have you ever experienced anything strange or unusual, like your voice is speaking to you and nobody's around? Right? You can ask those 20 questions, but then there's other things in your mental status exam that are observation. Like what?
Appearance.
Okay. Motor too. So you can, I did hear some of you ask about motor abnormalities, kind of like this. What else? Insight and judgment. I mean, in a sense, you can ask about insight, but you're not going to say, how's your insight? Right? It's really something that you're going to decide based on the conversation. Status exam and how this is part of a mental status exam, right? And because it's a cognitive screening test. Now, we've talked about these things in psychiatry, so we're just going to review. but in the ER, you potentially may have suicidal patients. They may come in because that's their chief complaint, or maybe not. Maybe they come in for some non-mental health reason, and you're astute and you kind of pick up on something, and you know, go down the mood questioning, and maybe they admit to suicidal ideation. I had a 2023 grad when he was in his psych, or no, he was in his ER rotation. Patient came in for just like vague abdominal pain complaints. And he interviewed and just felt like something was off, and asked him about his mood, and come to find out this patient was having suicidal thoughts. So did not present for that at all. Probably would have never came out with it. Picked up. So, you know, sometimes these things can be missed. Young females, 15 to 19, are more likely to have suicidal thoughts and come to the emergency department after non-fatal attempts. You might think of someone like this as someone who cuts, right? Non-fatal, but still they need evaluation. Absolutely. All mental disorders are associated with mental disease. Remember, what's the most common method of suicide attempt? What is it? Hanging? No, not hanging.
Pill ingestion?
Medications. Drug overdose. So, we talked about this in emergency medicine. I know that for a fact. Certain medications and so sometimes when people are on specific medications that you can get a level medications where the level tells you something, you know, that's something you need to consider. What psychiatric medications can you obtain at blood level? Lithium. Depakote.
What type?
Some TCAs like nortriptyline. What do we know about TCAs and overdose?
Fatal killers.
Causes like arrhythmias, very, very dangerous. What's more safe than an overdose, an SSRI or TCA? Okay, speaking of, you have a patient who comes in who took too much Prozac. So we're not necessarily worried about that EKG, though we want to get one as much as we would if it was like a tryptophan or amitriptyline. What are we worried about?
Serotonin syndrome.
Serotonin syndrome. I know someone asked about serotonin syndrome. Or educate is about serotonin syndrome. Remember what it is? So, you know, that
What?
diarrhea, this is
Is it headache?
that we need to be careful with. It's not just psychiatric medicine, right? You can have somebody who's on maybe an antidepressant, but then they're on some other medicines that have serotonergic activity, medical medicines. That could come in
It's a crazy
play.
word.
So you need to be able to. Diarrhea, shivering, hyperreflexia, hyperthermia, instability of vital signs, encephalopathy, restlessness. Serotonin syndrome is a spectrum, right? There's some people who are real sensitive to it. I had a patient who was very sensitive. He never presented necessarily, you know, in emergent condition, but he would feel restless and have sweating and those kinds of things if his dose was too high. He was very, very sensitive. So remember, it's on a spectrum. How do we we treat serotonin syndrome, we want to get rid of the medication and give supportive care. There are serotonin antagonists that could be given. It just depends on the severity of the symptoms. What is the equivalent of serotonin syndrome for antipsychotics?
NMS.
NMS, right, what does that stand for? Neuroleptic malignant syndrome. So remember, taking it back. Somebody who's taken too many of their antipsychotics, this is something we wanna have on our mind as a differential, or maybe an overdose. Life-threatening syndrome of fever and muscle rigidity. So you may see motor abnormalities like tremors, vital sign, lability, CPK and white count are elevated. And if a patient has comorbid medical conditions like dehydration, other medical conditions, they may be at more of a risk. For NMS, again, this is not everybody has NMS. But it's something that you need to think about. It's a higher risk when you're using higher potency antipsychotics. For example, or they're getting those antipsychotics intramuscularly. Right, it's been kind of like an escalated amount of medicine over a quick period of time, more evidence. But because it presents with a fever and such, you've got to rule out medical conditions. How do you treat NMS? What's the first thing you do? Stop the medicine. And give supportive care, and there are some medicines that you can use as well. The canceling number 15. And last case, and it's probably not the most common, but ECT can be. I don't know what you mean. This is a review. When we are assessing and managing patients that are suicidal. What do you want to ask them if somebody tells you they could have a suicidal thoughts? Do you have a plan? Okay, what else? What if they say yes? What is the plan? Okay, what else? Have you tried, how far have you gotten? You know, is this a thought, this is a plan, or you set things up, you have a date and a time, right? How specific? Okay? And do you have access to things, you know, things that you need weapons, or access to things that you would use to carry out the mission? But if you're assessing them and they came to see you in the emergency department, that's a good thing, right? Remember learning about a risk assessment, suicide risk assessment, and what that entails. I also was pleased to, this is a great one to do after that, to hear some of you say, you asked about suicidal ideation, which was wonderful, and also include that in your plan for the panic case if you were to have those thoughts. You need to go to the emergency room. I heard some people ask about passive death wish as well. Good. You remember what a passive death wish is? It's like, you're not having suicide, you don't want suicidal thoughts, but if something were to happen to you and wake up the next morning. Remember, there's certain risk factors that put people at a higher risk for suicide attempt and completion. Remember, we identified men over 65 that are unmarried, unemployed, living alone. Again, if you've got things like a history, a past history of suicide attempts, and you all asked about family history, at least of, psychiatric conditions, because that puts you more at risk. What are some other risk factors for suicide? Let me start with this. There's static and there's dynamic. What's the difference? The static risk factor and the dynamic.
Static, you can't change.
There is static risk factor, it's unchangeable. So it is what it is. What is a dynamic? Something that you might be able to change or intervene, right? So you can't change your family history like Becky said, but maybe, what's an example of a dynamic risk factor? Say again, right? Yeah, substance use, okay, good. So what are some other risk factors that we didn't talk about? So we just said substance use. Said personal history of suicide attempts.
Education,
Anything else?
like education, lack of education.
Okay. Lower education level. EBI. Having a chronic medical issue. Or having a psychiatric illness with pretty severe symptoms, like severe anxiety, hallucinations. Who commits suicide more men or women? What are some protective factors? So when we do a risk assessment, we want to know, I want to identify this patient's risk. What puts them at risk? Are there things that put them at risk that they can't change? Things that put them at risk that maybe, my role as your clinician is to try to work on these dynamic risk factors that we can change. But then on the flip side, what are some protective factors?
Patient provider relationship.
Relationships. Okay, I heard a lot of you asking the kind of patient about, their relationships and the difficulties with family and friends. Definitely. Even a therapeutic relationship with a provider, very helpful. They can't get after it. Yeah.
Either being spiritual or having some sort of spirituality.
For sure, for sure. Yep, spirituality, Ajay, you said employment. Having a responsibility for others, maybe you have a family or a pet or, I've had lots of patients who maybe if they were single and you couldn't necessarily have a family, they'd say, I could never do that to my dog. These things are important. Because your job is to try to figure out like how it can start that, what can you do to help them to do it. And make them less at risk, right? When you're doing a suicide risk assessment, you shouldn't always solely depend on what your patient is doing. Because sometimes you have to decide whether or not to feel like it was illegal. Because some people who are really resolved to end their life may see you as kind of blocking. So certain things, certain clues for worry, are they giving away their possessions? Are they writing a will? These types of things. It's like a plan. It's nice to get collateral information. Really, you kind of are a detective and figure out, gosh, if I'm in ER, should I let this person go home? Do I think they're going to be safe or not? And remember, sometimes suicidal ideation is a malingering symptom. Why might somebody come into the emergency department and say they're suicidal? Yeah, they have somewhere safe to stay, shelter, food. Right. if, you know, if you're in the emergency department and you're not admitting your patient, like our panic patient, she wasn't admitted from the emergency department to a floor. You still needed to help come up with a plan, structured plan for your patient. You know, where do you want to send them? So for our panic patient, their plan was, you need to go see your primary care tomorrow. When you're discharging someone that maybe you admitted and they were suicidal at the time, you know, before you discharge them, you want to feel confident that they are no longer feeling that way. So obviously, you know, documentation and, you know, what's different now than when you came in to the hospital. You know, you're telling me you're no longer feeling this way. What's different? What's changed? Those are good questions to ask. Sometimes the difference is you treated me. You put me on an antidepressant. I was depressed, you know. You helped me with my anxiety. I escaped, you know, and gotten my mind clear for a few days. So I've been clean and sober for a few days, and I'm, you know, not thinking as erratic. And we kind of talked about, Lydia brought up the fact that sometimes people might need a sitter while in the hospital, especially if they're, you know, worried about suicide, because some things are really complete suicide while you're in the hospital. So just to review, we've also in the past talked about child maltreatment, abuse, and neglect, and these are not fun topics, but really important topics. And so we're talking about any acts or failure to act on the part of parents or caretakers that may result in serious injury, emotional harm, sexual abuse, or death of a child. And typically a perpetrator is going to deny any abuse, and sometimes children fear disclosing abuse. Neglect is the most common form of child abuse. And it's not, children can be harmed by, you know, withholding of necessities. You had a clinical correlations Blackboard case about a geriatric patient who we were concerned for abuse, right? So as a healthcare practitioner, you are required by law to report orally and in writing any suspected child abuse or neglect. Who do you report it to?
CPS.
Right. And then what happens? They investigate. So you're not doing the investigation. You are just making the report that you are suspicious, and here's why. That's what you are required to do. Lots of different potential signs of neglect or abuse which we have been through. But specifically for children, frequently missing school, just not being cared for, showing up dirty, not having the right kind of clothes for the weather, unexplained injuries or marks. I think you've been through a couple of cases where a child came in with an orthopedic issue, and you know, on x-rays you saw maybe some old breaks and things like that. So that also is a potential sign. Running away, engaging in self-harm. And then switching over to elder abuse, same way. Elder abuse can be physical abuse, psychological, emotional abuse. sexual abuse, maybe financial abuse, you know, they can't manage their money anymore, so you're helping them. That's fine, but, you know, what are you doing with their money? Is it in their best interest or yours? Neglect or abandonment, medication abuse. And elder mistreatment is really common. And really, it can occur anywhere, right? You probably think, oh, in different, like nursing home, things like that, but it can happen anywhere. Home, in a long-term care facility, by anyone, family, friends, caregivers. So who do you report suspicion of elder abuse to? Adult protective services. And then intimate partner violence, we also talked about. Psychiatric medicine. Can affect anyone, but women are more often victims than men. And this term kind of describes a variety of things: actual or threatened harm, psychological, physical, sexual harm by a current or former partner. And it can occur among people with any gender identity or sexual orientation. It doesn't require that you've had sexual intimacy. If you suspect this, who do you report it to?
Try to talk to the patient first. Yeah, you have to talk to the patient first, because if they don't want it reported, you could put them in more harm.
Bingo. Bingo. This isn't something that you report unless they ask you to help them with that. So some more kind of history or observations that you might pick up on during a physical encounter that might clue you in to intimate partner violence. So again, constantly or frequently showing up with different injuries and kind of an inconsistent explanation. Missing appointments. Having kind of a different affect. Overly attentive and verbally abusive. And in some locations in the ER, probably in a lot of ERs, you know, I did hear some of you ask the panic patient, like, do you feel safe at home? Which is fair, but does the panic patient live with anybody at home? So when you ask that question, what were you getting at? You getting at, like, you know, it's been partner violence or, you know what I mean? Like, I think somebody just asked it, like, but I was like, well, wait a minute. And I'm not saying you shouldn't have asked something along these lines, no, but maybe that home thing. You live in home, yeah.
I was gonna go like paranoid about.
I do. I think she made me feel significantly worse about this.
Something like along those lines.
Yeah, but you've got to define what you're asking for, because asking someone if they're safe at home could mean many different things, and I don't think to them. I would ask more specific. If you wanted to ask that, I would ask that more specific. But in your encounters with them, has any paranoia come about, or has this come about in your conversation with them? Right. Did you ask about perceptual disturbances in your mental status exam? To your panic patient? Some of you did.
Next time.
It wasn't.
Yeah. I was playing that on my next visit.
But anyways,
with them.
there are surveys.
We'll do the calling. Right, yeah.
Certain types of
Exactly,
screening.
exactly. They might not know it, but I was there.
This, you know, it's probably really commonly done. Ways to frame your questions. And maybe, you know, if you were getting at that with the panic case, okay, I'm not gonna tell you that's wrong, absolutely not, but are you safe at home? Like, maybe you wanted to consider something, one of these other types of questions. And if those things come about, then if there's a significant risk, you need to help devise a safety plan. As the patient could be at really risk of harm or death. The case I gave you in clinical correlations, we worried that the son was, somehow abusing or neglecting, right, his father. And so potentially if you're in the ER and you suspect this, you could admit the person. If they're willing, you can't admit them. But if not, what's their safety? Maybe they need to gather some sort of emergency kit that they can just take and go with important documents, keys and money, other essential items. A backup place that they could always stay if something gets bad. Or having some sort of signal if they see a neighbor or a friend to alert them to call 911. And, talking about, okay, if something is escalating at home, me and you and your partner, a partner, avoid being in rooms where things can be used as weapons. All right. That's all I got. Questions?
Looking about the show. What else could it be? So, first we have to rule out the serious stuff. And treat it empirically, try to figure out what's going on. We use AEIOU tips, which I've spoken about.
No.
Infection, you want to use antibiotics early. And often, if it's an organic cause, there's going to be a loss of orientation. Orientation, time, place, who they are, who the president is. When I was, I had a patient who, a few years ago. So I said, so, she had struck her head on something. The president? And she said, Obama. No. Oh, you're right, Clinton.
Wrong one.
JFK. She said
Washington next.
she skipped over Trump here. Which she's clearly been on like 8 years, right? But, and then I was like, you sure she doesn't wait, well, Biden. Okay, well, I still think you need to go to the emergency room, but that's not okay. All right. So that's a class cancer you didn't pass. And I was elected when I was organized to reach that on people. And I said, the president is about
I'm not gonna tell you. I'm not gonna tell you, it's crazy. That's some side issues going on.
Alcohol. Because this epilepsy is causing this altered mental status. Because not every altered mental status is a lack of orientation. Sometimes it can be a lack of consciousness. What we're going to do. We need insulin. Is there some sort of metabolic issue, overdose, toxic, bulimia, trauma, infection, psychiatric or poisoning, and then stroke or that. So when they come in, it could be an organic cause, which could be structural, it could be metabolic. It could be functional altered mental status, which we really don't know what's causing it. No identified pathology. There could be a mix of the two. And again, like you said, it tends to be disorientation to go with the There are levels of consciousness. So that is with pediatrics, way back in the fall. So it could be conscious. Most of you are right now. Could be sleeping. And then lethargy, stupor, sedation, and finding coma. Being obtunded in coma at a certain point, they're getting a little difficult to discern semantics. Lethargic would be where they are continuing to sort of doze off while you're speaking. Not that they just have an entire emergency, but they are actually dozing off in the middle of speaking. When you're assessing them, you want to check their pupils for size, reactivity, use of Glasgow Coma scale, which is based on eyes, verbal, and motor. More than 13 is a good prognosis, less than 8 intubate is a bad prognosis. If it's a depressed consciousness, obviously, what can't you do when you're doing that neurosis? Well, you can't really do sharp indulgence. You can do hot, temperature, you can't do vibration. Right? Those are part of the neurological exam, or even strength. You can't do the first neurological exam because they have depressed consciousness by definition. That's when we have to go to the Glasgow Coma. This is really important to know, which is super important to know in general. So eyes are on a level of 1, 2, 3, 4. Really easy. Everyone is a 4 at baseline. Verbal, 3 would be, can you open your eyes? They open their eyes. Very easy. I'm going to skip pain for a minute because skip over to the motor as well. Again, everyone here, verbal is a 5. 4 is they don't seem to know who they are, where they are. 3 is they are saying words, but they're inappropriate to the questions being asked. 2 would be they're moaning, they're saying something, but they're not getting it. That seem like words. And then again, 1 would be the base. So someone who can be borderline deaf, it's easy as a and then going over to motor, following commands, again, almost everyone in this room. 5, purposeful movement, right? Rest of the room. Withdrawal to pain, and now I'm going to circle back to 2 because we're talking about someone who's not opening their eyes for pain. So what can you do to get them to react? Then you never see this spinal route. Take it up like this, dig it into the sternum. That gets a reaction. Okay. They'll either try to back you away, or they'll open their eyes, or hopefully both. Right. And then decorticate versus the cerebrate. Positioning. Cerebrate is an extension, and then the motor is actually no. What's the difference between the cerebrate and the decorticate? With the cerebrate, the head and neck are arched, right? The legs are straight, everything's pointing, if you will, away from the head. All right? Muscles are held tightly. And this is usually a fairly, both these positions are fairly significant range. With the cerebrate was that abnormal extension rigidity. With the corticate, everything is coming in towards the heart, towards the core meaning heart, right? As between flesh and rigid towards the heart. Right, the internal rotation. So shoulder adduction. The legs are still extended, but the legs are they're internally rotated. And again, the toes are hyperextended, but they're being that interflexion, turning inwards. So the corticate is inwards or outwards. And the cerebrate is what else defines altered mental status? Well, behavioral changes, appearance, dress, memory, short term, some long term as well, and inability to concentrate, move, thought, accomplish, credit. So there could be clinical states of cognitive acute confusion, states of severity. There's also psychogenic conditions, amnesia, akinetic mutism, right? Let's see. What is akinetic mutism? So these are people who are aware of what's going on. They have an intact level of consciousness, decreasing their goal-directed behavior. Okay, so we just terms to use that locked-in state. I don't know, but they're very clearly aware of everything that's going on, but they are not moving information. And then there's a pseudocoma, psychogenic or chronic. Easy test to rule out pseudo or rule in pseudocoma. They seem that not be responsive. And you suspect pseudocoma just to this fine. Lift up their arm till it's over their face. Let go. See what happens. Usually if they're faking, they will stop themselves. If you really suspect it, and I think not. The face, just anything where they sense their hand moving forward, usually there'll be somebody stop. You said if you some mistaken there, and with the smell, they can be an osmio. Bleach. Bleach does not use granular one. It's a smell, it uses nociceptors. So even people who don't have osmia smell bleach. You don't have to. Okay. So normal mental functioning, this is people who are awake, alert, joint cognition. All that requires some functioning both in the cerebral cortex or related to a particular activating system. Or your AMS, we'll come back a little. RAS is located in the brain stem, and because of that, it's affected more easily by displacement, by compression. Smaller lesions in the brainstem are obviously going to have much greater effects because it's a much smaller area. But it is more resistant metabolically. Okay. So if the RAS, if the problem is if the concern is something in the RAS, you can more likely to be some sort of structural issue, displacement, compression, metabolic is more likely to be cortex. If there's bilateral disruption of the cortex, that becomes again more often metabolic structure on the space. In that case, the cerebral cortex would be more sensitive to that. What is a coma? Definition of a coma is the failure of both arousal and the content function. Yes, we did probably as far as we can. Or we, as far as we're concerned, there's failure of the function. So what happens with the coma? Just to get a better idea of what happens. Normally, you have a consciousness maintained by the normal functioning of the RAS, midcons, bilateral projection. Hemispheres. Coma comes from lesions that affect either the RAS or both. Just to get a picture of it. So what could cause it? Well, it could be you're missing basic things you need in order to function. That's basically metabolic substrates. You don't have your basic building blocks, right? So you have hypoxia. You have tissue hypoxia, cerebral ischemia, maybe because decreased cardiac output, maybe because decreased arterial vascular resistance. All these are other names for shock, right? Or localized high peripheral vascular resistance, meaning it's not allowing it to get there, or an occlusion from the arteries. It can also be because of lack of blood sugar, hypoglycemia. So anyone who comes in unresponsive, one of the easiest, quickest things we do is the blood sugar, right? And could be some cofactor deficiencies. Might be from some sort of disease, whether it's an endocrine organ or a non-endocrine, right? Or some other systemic disease, cancer, or it could be final thing that could be causing is either some sort of lesion or hemorrhage, or some sort of imbalance, the arrangement of certain thermal regulation of eating. There is something called the Cushing's reflex, which is someone has increased ICP that causes hypertension and bradycardia. The questions on possible causes. causes that. Now, just again, out of curiosity, what is one of the oldest surgical procedures performed by humans that we can actually still use today? Nation,
What I said.
all of that, right?
You say look up. That's what I said.
You can do it for anything, but now we try to limit when we decide to go over your head, but it can be something to help with. In general, don't go over. All right, so coming in, they're not conscious or have a GCS especially under 8. Obviously, we want to get airway control, ABC, oxygenation, ventilation. Keep the spine. You want to maintain spine control, especially if you're worried about some sort of trauma. Keep in mind the cardiovascular status. Check your AEIOU tips. Is it from diffuse impairment in the brain, or is it focal, which might be treatable? Try to figure out, was it abrupt, meaning stroke or a seizure of some sort possibly, or was it progressive? This was coming on for a while, maybe hyperglycemia, maybe, or maybe something. Take a look at the vital signs, if it has medical history, if there's no good history, if you're able to do someone. Or looking back at the chart. Physical exam should include tone, especially including rectal tone, corneal reflexes, taking a look at their posturing, one of the really good differential diagnosis. And again, part of the vital signs are going to be oxygen and temperature, right? Because hyperthermia and hypothermia can both cause decreased consciousness. In these cases, simply when they want to do with or without. Without, why?
For a bleed.
I want to make sure I don't have a bleed, right? If you think there might be a mass at some point in the future, you could do it with contrast. But right now, you want to do it without. With contrast is to look at structures. Without contrast is to look at. If that CT is not remarkable, it's like a normal brain, then you can do an LP, a lumbar puncture. Okay. What are some things you might find in them? Find blood in the lumbar puncture. Be one of two things. Could be a bleed, yeah, or it could be a traumatic LP. I see dendrochromia in the CSF, meaning yellow red blood cells. They sort of already started to break down. Then what is that? That's more likely because it means it's been in the CSF for a time. What if the tubes just don't make it down to the lab for a while, and then they find it? Those traumatic LP, you'll know because you might see some blood coming in the CSF. Might be that. What do you want about resins? Infection, like meningitis. What if there's not a ton of white blood cells in the grand scheme perspective? Could be viral meningitis. Okay. If you're worried about some sort of clot in the MRI or in the basal artery, excuse me, everyone gets it. Now I'm going fast. Hopefully some of this feels familiar. A lot of what I read through was very. Any questions what we've done so far? What do we need to be aware of? So listen, if it was coming from trauma, now they're coming in under trauma, you have to keep the C-section stabilized. Always protect the airway, especially if they're not responsive. You don't need to protect the airway if they're conscious and responsive. Just because that's not enough. But if you are worried that they're going to very quickly become you need to consider rapid sequence intubation. And again, just because I like making this cross connection, when would you When would you consider rapid sequence intubation? Because it's getting 2 hours. When something's slowly on.
Burns to the birds.
Slowing to the face, very good. So you have to worry that airway is going to become edematous. We're going to go down so quickly. The good news is, he's explained them like Mike Jones, right? That's. Children consider, is there possible injections involved? Did they get into their parents' marijuana or LSD, right? Are there infections that could be causing it, child abuse? Are they non-responsive because maybe they had honey and they're 1 or 2 years old, now they have symptoms paralysis, all that? Or just get some sort of virus, now they have an symptom paralysis.
Guillain-Barré.
Yes. And you did a body check, you didn't see a tip. Does they have a generalized seizure? And they come in unresponsive. So consider they might still be having a seizure. It's just become non-convulsive, maybe even a subtle sinus epilepticus. How do you manage it? Control seizure activity that's occurring, treat infections, treat the elderly very carefully. Empiric therapy, oxygen is always good. Thiamine, if you think there's an alcohol abuse history. E50, based on the care glucose, Narcan again. Possibly from Flumazenol, it's Flumazenol.
And so.
Very good. And then MAG, calcium based on their blood work. And then consider drug or toxin exposure, getting a touch screen. If the ICP is increased, get the neurosurgeon on board to tell you what you should do. Consider intubation. You should intubate. Mannitol, hypertonic saline, dexamethasone, that are associated with it. And avoid using hyperventilation during the first 24 hours after a brain injury. But when they're intubated, so what do you do? Who stays and who goes? Well, if after doing everything you can, and they still are having alternate status, they need to stay. If they're suicidal, they need to stay registered suicide. And hypoglycemic patients, if on oral diabetic meds, not insulin, that's why they're having alternate status. They also need to keep in mind a lot of those oral diabetic meds, if you play with your blood sugar, you just give them sugar and say like, okay, you're good to go, right? Sometimes they're resistant to insulin. Even if they start to get a little better, they might have some. But who can come home? Who can go on? Let's say like their insulin pump just got funky and gave them too much insulin. You get their sugar back up, everything looks good. So if it was easily reversed, they can go on. I would make sure someone is staying at home with them. Don't do that to people who are by themselves. If there is, if it is from some sort of drug injection, we can get back to normal status. And out of your system. There's acute alcohol intoxication. So this is tricky because you need to have an informed decision. This is a patient who is an alcoholic or alcoholic. You need to make sure that they can have an informed conversation with you about whether they want to treat it for their alcoholism, or if there is an underlying alcoholism. They don't have that when they first get to the so you have to find out what the legal blood alcohol is. Have them hang out with you so you get that alcohol down. And then when they're sober, able to have this legally informed decision, which is hard because sometimes they're just not getting down to that level you need them because they come in with very high blood alcohol. But they seem pretty with it. There's like so much gone to them. That's already wishy-washy in a real practical world where you can call it infarct. decision. But officially. And, if they have someone come who can be with them, if there's appropriate follow-up, no social consults, there's no social reason why they should be admitted, being a very clear cause. Now they're mnemonic for a differential of what's causing the altered levels of consciousness, is mood stupid. Tips, right, for some reason. Remember that? This, by the way, I think I saw in a pediatric. So. Maybe AIO tips for your adults. Kids say mood stupid.
Don't say sit down and.
Yeah.
So obviously, real serious causes, premium for number 80 tips, early antibiotics, infection, organic parent, patients are the ones that are going to be disoriented, meaning hospital. I have a few cases. So I got this from ED medicine, how to deal with patients with delirium and emergency rooms. So I'll give you a